Okay, hello and welcome to the Playing Film and CT webinar. My name is Seidel and I'm the Customer Success Specialist, Collective Minds. This might not come as a surprise, but Imran is actually here here at the HQ, which is truly amazing. So,
my name is Dr. Lasker. I'm very, very honored to be in the headquarters of Collective Minds Radiology in sunny Stockholm. And it is actually sunny, but it has been cold. And me being me, I was a bit ill prepared for when I came out and I had to go buy jumpers and jackets and all that kind of thing. So for those of you that have never been to this webinar before, I go through some interesting radiology cases. We go through some difficult cases, really easy cases, and then some difficult cases. And we really do welcome as much interaction as possible, because without you guys, we don't really have much of a webinar. Without the interaction, without people giving us cases to look at, it can only get so good. So, obviously, I need you guys to help me make it as educational as possible. So without much further ado, you will hopefully get a link in the chat to be able to access the cases that we have. And I'm going to start sharing my screen now. And hopefully everyone can see that. And I'm going to open the Q&A and the chat area as well. So if anyone wants to ask any questions at any point, if you want me to go back to another case or whatever, we've done this plenty of times before. And I think there is some real value for the questions that people do ask. And the main thing is just to have a good time, listen, hopefully learn something together. So what we'll do, hopefully everyone has got that link now, and we're going to go to case number 1 and just have a quick look and see what is happening here. So as we go through this, I'll explain. And if you think that you know the answer, just throw it in there. Just tell me what you think. And if you've got any questions, then do let me know. So what we're doing here, we've got a shoulder x-ray right over here. And we're using Collective Minds, which is the platform that I use for my teaching and for my actual online teaching business called Radiology Seminars as well. Really, really good platform. And you kind of do get access to all the diagram viewer features that you would require. And actually, recently, they've added this pencil function, which is really great for me to be able to do my teaching with. So we're looking at the shoulder. And has anyone seen it? No one's said anything just yet. Yeah, so someone's come out with it. So what we'll do, you kind of just look at things and you draw a line all the way around that humerus, and there's a bit of overlap of soft tissue and all that kind of thing. And then you also draw the glenoid over here. And you may say to yourself, well, actually, you know what? These two are aligning quite nicely. There's no dislocation, but actually you've got to look at the direction at which the humeral head is pointing. And you can actually see that the humeral head is pointing this way. And the glenoid that we were drawing out earlier is all the way over here. So this is here. And the glenoid humeral head, so the humeral head is pointing this way. So therefore, there's quite a big distance between the two, meaning that this is some sort of dislocation. Now, someone has said anterior dislocation. Yeah, at this particular view, you'd say, yeah, this is an anterior dislocation. But then you also have to have two views, because there have been occasions where on one view, someone has called a dislocation, and actually on the second view, it looks okay. Now, yeah, in theory, what could have happened is that you took the x-ray, then while you're getting the plate ready, you go and take the next x-ray, and in the interim, yeah, the shoulder could have got back into place. Less likely, but could happen. But it's very, very useful to still look at the other view and see what's happening. So what we have here, for those that don't know, is called a Y view. And the reason it's called a Y view is because this scapula looks like the letter Y. And so this must therefore be the central aspect where the shoulder should really be. And in fact, you see that shoulder has gone all the way forwards like so. And how do you know it's forward, which one's back? Well, you're going to have your coracoid process going forward, and that's going to be the most anterior aspect of the shoulder. And the acromion and all that is going to be the posterior aspect of the shoulder. So this is going to be forward and this is going to be backward. And therefore, that humeral head being all the way across there is going to be sort of a bit too anterior. Now, the other thing I want you to think about is, fine, you spotted the anterior dislocation. What is the next thing that we should be concerned about or worried about when we're looking at anterior dislocations? So when you get anterior dislocations, that humeral head is going to go forwards. And actually, a lot of the time at the initial point of injury, it goes quite a lot further forwards than you will see on the x-ray. And when it does that, your body tries to bring it back into place. So your muscles spasm up and try and pull it back into place. And because it can't quite do it, that posterior aspect of the humerus ends up hitting the inferior aspect of the glenoid. So you can end up getting a fracture over here, and you can also get a bit of a dent in fracture over there. And that fracture on the humerus is known as a Hill-Sachs fracture, and down here is known as a Bankart lesion. So then what you need to do is really zoom in and just try and see whether you can feel as though there could be something going on there. And although I can't be 100%, I do feel like there could be a bit of a radiolucency just there and just there. And that would be a very, very kind of typical area for a Bankart lesion. So at the very least, someone like this will end up needing to go getting a CT scan, getting an MRI scan to have a closer look at the glenoid. Now, the other thing to remember is that you've got an osseous Bankart lesion, i.e. a fracture, but you can also get like a soft tissue version where you've got an injury of the glenoid. And the glenoid is like a suction cup, like a fibrous suction cup, and it holds that humerus in place. And when that dislocation happens, sometimes you can hurt the suction cup rather than the bone itself. And when that happens, you can't see that on X-ray, because X-rays are only good for looking at fractures, but not so good for looking at soft tissue injuries. And so in those situations, you may end up needing to get an MRI scan. So yeah, someone's come out with it very, very quickly. The only thing I'd like to highlight in what I'd say is a simple-ish case is I always keep looking for the next finding and the next finding and the next finding. So this one, I wanted to try something, get a little bit of interaction going with this particular case. So there will be hopefully a poll coming up in just a minute, trying to get you to sort of interact and tell me what you guys think of this particular case. And so here you've got this poll asking you whether you know what sign this is. And I'll be honest with you, some of those signs I've just made up. But for those of you that can't see it straight away, no worries. What we'll do, we'll have a look and see what's going on. Now, when you look at an X-ray from the beginning, you try and think to yourself, okay, first off, young or old? Is this patient a young patient or is this patient an older patient? And actually, there are a few clues that tell you kind of that they're not a child, because you can look at the humeral necks and you can see there's no growth plate there. There's no growth plate there. So you're probably looking at an adult at least. But the thing that kind of makes you realize that actually, you know what, this person, someone's very quick. Don't worry, I've got some more difficult cases for you coming up soon. What you then do is have a look at the aorta. Can you see that kind of hyperdensity going around there like so, and the hyperdensity going around like that, like so. And again, I'm just going to show everyone with the magnifier function here. And you can see, look, if we zoom into there, you can see, yeah, there is this hyperdensity located in that like in the circumferential distribution located within the aorta. Now, generally speaking, that should only really happen in someone who is a bit older. They're going to be way above 60, 70, way above that. And so that kind of tells you that, okay, we're not dealing with a very young person. We're not dealing with a child. We're dealing with a lot older adult. And then you got to start looking around, like what's going on with this X-ray? Is it normal? Is it abnormal? It looks okay at first glance, right? And so then you got to start using what I'd say the check areas. So if you learn nothing from me apart from this, the check areas, then you should be able to pick up most abnormalities that can come up on an X-ray. So my check areas have always really been the costophrenic angles. I look at the lung apices, and I'd also look behind the heart. Now, when it comes to the costophrenic angles, someone has come out with the answer, which is great. But look, that costophrenic angle looks very, very sharp, doesn't it? It looks very, very sharp. Like you could literally fall into that little crevice, that little valley. But here, it looks like it's a bit more cushiony. It looks a bit flatter and goes around like so. And because that's blunted, straight away, you should be able to say that, okay, I think there's a bit of fluid in there. And actually, when you look a bit closely, you can see that, yeah, there does seem to be a bit of a radiopacity going this way and this way, covering up that area, meaning they've got what is known as a small pleural effusion, blunting that left costophrenic angle. So we're done there? No, we've got to keep looking. So lung apices, just have a look at the lung markings, and the lung markings look okay. So we haven't seen anything grossly abnormal in that area either, which is good. And then you want to be looking underneath the hemidiaphragms as well. Just make sure there's no air under the hemidiaphragms, because otherwise that could be a perforation of an intra-abdominal solid, intra-abdominal viscus. And then when you look behind the heart, you've got this cardiac, you've got the aortic knuckle there, you've got a cardiac border there, but then you've also got a kind of a border there. And that's when you start to realize, okay, this must be the abnormality. Something's happening here. Now, if you look at the questions I've given you, I've asked you, is it a Popeye sign, a continuous diaphragm sign, a golden S sign, a golden Labrador, or a sail sign? Now, I'm going to draw it out for you just in case you're not entirely sure what it is. It does look like a bit of a sail. Hang on. Yeah, it does look like a sail. If you do this, you could draw it like so. It does look like there's a bit of a boat here. And so this is known as a sail sign. Exactly right. Someone said that. So that is a sail sign, and that has basically means that there has been a collapse of the left lower lobe, and basically the left upper lobe has hyperexpanded into its base. Now you may be thinking to yourself, hang on, if there's loss of lung volume, then why have I not seen much in the way of deviation of the the trachea towards the left? Why have I not seen much in the way of elevation of the hemidiaphragm? And why have I not seen much in the way of elevation of the hilum? And this is where you've got to start thinking, you've got to try and explain away why those things are not there. So they may be there, but we also have to try and look at the quality of the film. And you can see the medial aspect of the clavicle is there. The medial aspect of the clavicle is there, but that spinous process is very much towards the left. So this patient is slightly rotated, and you'd almost be, and most likely going to be slightly angulated as well, because you can't really see that heart border that you'd otherwise see. That's all pointing towards the fact that this patient's rotated, slightly bent forwards, resulting in this appearance of the lack of some of the findings that you'd otherwise expect from doing this from seeing this kind of sign, the sail sign. So they may very well be there. We just may need to have another X-ray to be able to identify the elevation of the hemidiaphragm, the loss of lung volume, the deviation of the hilum, and that kind of thing. Now, with these patients, you have to take things quite seriously, especially someone who's slightly older. It could be a malignancy, an endobronchial cancer, it could be a lymph node that could be causing blockage of the lung over here, which is resulting in lack of aeration in this area and resulting in that complete collapse of the left lower lobe. So yeah, really great. Well done. A few people have got it. Don't worry, they will get more difficult as we go through. Let's have a look at this one. So this is an elbow, and hopefully this is straightforward. If not, don't worry. This is the whole point in trying to learn from one another. We'll get the pencil thing out here. So at first you may think, well, nothing abnormal that I can see. And one of the things I always try and encourage people to do is draw the champagne glass. So it looks like this. There's a stalk of the champagne glass, and then you've got the bottom of the champagne glass there. And so then you've got to try and see whether that champagne glass is broken down the middle, because that's sometimes what you'll see. And that would be in keeping with a supracondylar fracture. But I don't think we can really say that that champagne glass is broken. But in the posterior aspect of the elbow, it actually looks like a bit of a valley. So it looks like this, like a bit of a crevice. And inside there's going to be some fat. And when you get a fracture, that fat kind of comes outwards, outwards. And you end up getting this sort of radiolucency coming out like this. And that's completely abnormal. And then when you look anteriorly, you can see a radiolucency like this, and you've got some increased density over here. So there is something up. There's a big effusion. Some of the posterior fat pad has been pushed backwards. Some people have got it already. Some of the posterior fat pad has been pushed backwards, and you've got quite a significant joint effusion. So then you've got to start looking. And 9 times out of 10, I'd say, is going to be the radial head. And the reason for that is when people fall, they fall onto their hands, and a lot of that weight gets translated into the radius, goes all the way back. And that weight just gets dissipated to where there's actually not very much bone to be able to take that weight. It gets a bit of a hit on the radial head and then ends up getting fractured. So it's all to do with the way people fall over in reality. And actually, when you look a bit closer to this, you can see that, yeah, there is this appearance of this radiolucency and irregularity involving that radial head over here and here. And again, you've got to go across to this view now and have a closer look into this area. So zoom in. And now you can really see how obvious that is, right? You can see that there is this clear demarcation of a linear opacity going this way, a bit this way, and there's like a little step deformity just over here as well. So this is kind of a classic case of a radial head fracture as a result of sort of impaction and the way the weight is distributed when someone actually falls over. Now, interestingly, when someone, generally speaking, this happens when people fall over, and someone is trying to punch someone else, they'd usually end up fracturing the hand. So they'd end up fracturing the 5th metacarpal, the 4th metacarpal. But when it's a genuine fall, generally speaking, you end up getting a fracture of the radial head. So as we're going to get slightly more difficult, we have unfortunately one view, but one view is sometimes all we need to try and figure out what's going on. So this patient's fallen over. They said they twisted their knee and they've had a bit of pain in their knee and unable to walk now. So things are getting quite bad for them. And so they've come into the ER as well, the emergency department, to try and find out what's going on. And on the lateral view, it does kind of show you what's happening. So one of the things I'd immediately look for is to look for whether there is a fluid level. And unfortunately, we don't have a fluid level, but there is this increased density located here. So we do have some sort of high density effusion. So there is some sort of trauma that's happened here. And someone said it exactly right. So what you need to do is I will zoom in and show you. So you've got your femur that goes down like so, and then you've got your tibia. So when you get your tibia like this, you draw around, you can see there's like a border there, and it goes around like so, right? But then you've got this abnormal border that's sitting here, and a bit of a line that goes between the two. And as you look closely, yeah, you feel there's a line there and a line there, and this doesn't seem to continue with the rest of the tibia. And when that's kind of away from there, like so, then you have to be worried that there's a fracture. And exactly right, someone said it, a fracture of the tibial spine. And more likely, it's going to be a kind of avulsion fracture of the ACL, the anterior cruciate ligament, because you've got a ligament that sits across like so. And when you get a significant injury, that can just pull off and end up getting fractured off. Now, actually, interestingly, this clearly has happened in someone who's a bit older than a child, because this person's got fused growth plates. Now, when you've got fused growth plate, when you've got unfused growth plates and you're younger, it turns out that the tendon's actually generally stronger than the bone. And so those kind of patients end up getting these sort of avulsion fractures, big ACL tears, but it's not the ACL that tears, the bone comes off. This is kind of unusual in some ways, that someone who's got fused bones has ended up getting this sort of tibial avulsion fracture there. So yeah, well done for that person that's picked it up very, very quickly. All right, okay. Come on, let's try and get something a bit more challenging. We're getting a little bit more challenging as we go through. So this is someone's foot, and they have come in. So tibial. So someone's asking, is the tibial spine same as a tibial plateau? Not entirely. So I'm just going to quickly go back to that one to try and explain. So open review mode. So the tibial plateau are generally going to be. So when you draw this and you look at it from the front, right, you're going to have this. And so this is going to be the medial tibial plateau, and you've got your lateral tibial plateau, and then in between the two is your tibial spines. And so what's ended up happening here is that the tibial spine has been pulled off, but the tibial plateau seems to be okay. Now, I'm not saying that, there may be a fracture of the tibial plateau, because you may have a fracture here and there could be an extension of a fracture going that way or that way. But on this plain film, without the AP view, it's very difficult to say where there's been a further fracture, whether that fracture's gone anywhere else. But I have seen genuine cases where it just sticks down the middle. The tibial spines have come off and everything else is left same. Is this spine the same as intercondylar eminence? Yes, it is. It's nomenclature when it comes down to that level. You're just saying the same thing. Tibial spines, intercondylar eminence is also the same thing. Yeah. Okay, so let's go through to this particular X-ray. Let's have a look and see what's happening here. So this person has hurt their foot. So what I always say to every single person that comes to any of my teaching sessions, I know it's painful, but you should really draw around every single bone. Is the same thing that is injured in Osgood-Schlatter's? No. Osgood-Schlatter's is where you've got the patellar tendon insertion into the tibia. I'm going to go back to that in just a second. So let's have a look at this X-ray. So one of the first things I always do is have a look at the metatarsals, right? Have a look at those metatarsals and make sure that they look very, very rounded and they don't look very sclerotic. They don't look dense. Because if they look dense, then you're probably looking at something like Freiberg's infraction. We don't have anything like that here. And then I'd always check the shafts of the bone, because sometimes you get stress fractures there as well. Again, we don't have anything like that. So we're not doing great in terms of going for the high yield areas. And then the next thing to do is to have a look at the alignment of the actual metatarsophalangeal joints. And you see, actually, yeah, these all align quite nicely, because sometimes you can get a fracture of the Lisfranc ligament. Sometimes you get fractures over here and everything kind of just shifts across. We don't have anything like that here. So we're going to have to go for the long run. We're going to have to go around every single bone until we find the abnormality. So drawing around. Yep, someone's got it. Awesome. So you go around, you draw. Everything looks okay so far. Let's pan across, and then let's draw again, and just see what's going on. And then there you go. Someone said it. There is a fracture of that medial aspect of that proximal phalanx. And then what you really need to do is try and see whether this has got any articular surface involvement. And so what we do, actually, what's really great here is that you can just zoom in and have a look using this function here. And you start to worry there could be a bit of a radiolucency here, going all the way across like so. So you may end up needing to do further imaging, like a CT or something like that. So someone has said that they think they've spotted something. So second proximal phalanx over here, and we zoom in. So stress fractures are very unusual to happen in the proximal phalanges. Normally they'd happen in the metatarsal. So I don't usually see that, but he's saying second, around here. So this is, you've got to be a bit careful, and I would be careful because you can see that there is the skin fold here, a skin fold here that's going to give you that feeling that there's something more going on there. But actually, when you go along, it looks very, very smooth, very, very straight. I don't think I can convince myself there's any significant fuzziness in that second area. And you're saying this on the other view. So let's have a look at the other view to see what's going on and try and find out what we're looking at. So let's do another zoom function here and just have a quick look. So zoom, magnify. and just see what's going on. So look, go around, go around, go around, go around. Oh, I think you're saying around there. Yeah, you've got to be careful, because I think if you go to the other side, you can see kind of haziness there, a bit of a haziness there. You could say that looks hazy and that looks hazy. And after a while, you kind of play the odds. I know it can happen, but you play the odds, right? You do play the odds. And most of the time, you're going to get a stress fracture located within the metatarsal areas rather than there. And in the view, having like definite pathology within this region that we saw, someone comes in with acute pain and, what looks like a positive sign there, you'd go for that. And in truth, I would maybe, it depends on the person, but I have a higher threshold for, a bit of fuzziness here and there. And I wouldn't personally call a second metatarsal stress fracture in that region. Right, so let's go to the next case. I'm just going to open that now. Hang on, okay, so we are back and we are going to be opening the next case. Oh yeah, someone was asking something about, Oscar Slatters. So Oscar Slatters is where you've got your patella, right? And then off the end of the patella, you've got your patella tendon. It goes all the way to the tibia. And then that's where you get the inflammation. Okay, so let's have a look here. So so just got to open this one up. Okay, so the other thing, by the way, I keep forgetting to mention that if you do find yourself in difficulty, or if you feel like the images aren't loading very quickly, then there's a little cloud button, and that downloads things locally to your basically your browser, your hard drive for temporarily, so it won't be there forever. And then you get very, very smooth movement in the viewer. So if you do have anything like that going on, then just try that and then let us know. Okay, so we're having a look at this person, and I hope that people can see it. But what we'll do, we'll zoom in and again start looking a little bit closer, and just sort of really draw lines. I really do draw lines going along like so, along like so, along like so. And around here, it feels like it kind of bows out a bit and comes out this way. And one of the things that you want to try and take into consideration is the cortical thickness, right? And what the cortices look like. And you can see that's very, very linear, very, very linear. And then around here gets a little bit hazy, a little bit thicker, and then goes thicker, 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 a bit hazy, can't see it, and then comes back again. And so that means that there's some sort of injury going on. There's some sort of increased sclerosis, increased bone formation. So whatever's going on is clearly going to be chronic. And around that area, you can actually see that there is this sort of fracture going across like so. Now, the interesting thing is that normally when you get fractures of long bones like this, they don't normally be horizontal like that, right? They're normally going to be diagonal, they're going to be oblique, they're going to be shatters. They're not going to be sort of linear lines like this. And someone said it looks like a green stick fracture. Now, green stick fractures really only happen in children because they've got very, very bendy bones. But this person is an adult, clearly, because you can see that there are no growth plates anywhere. And this is a chronic situation. So for those of you that don't know, look, these are the growth plates and they're completely fused. So this is an adult. And so it's unlikely you're going to get that sort of bendy area. And exactly right. What this essentially is a stress fracture. And so what's happening is that you're getting a weakness, and let me just, you're getting a weakness in that bone and it's starting to get fractured. The body's trying to heal itself, doesn't quite heal itself, and ends up keeping going with this sort of stress response, like fracture gets worse, gets more sclerosis, gets worse, gets more sclerosis. Yeah, and so basically this is a part of a larger problem, which can happen for many, many reasons. But this is a stress fracture. And it's quite important to know that this is a stress fracture rather than acute injury, because the treatments will be completely different. Like one's going to go to the orthopods and get treated in that way. And the other one, we're going to have to start looking at the bigger problem of what's actually happening to that person as to why they've ended up with stress fractures. Okay, so let's go to the next case. Yeah, so a few people came out with some good answers there. Excellent. And there are some good places to, so it's a good practice to describe the direction of the stress fracture. In truth, when you say stress fracture, it's kind of pathognomic for what you're trying to say. You can do, there's nothing wrong. I do like I'm maybe because I'm slightly more verbose, or I like to write lots of things. It's quite good to like try and describe things as much as possible. It may tell you it may tell you a little bit of detail as to like how serious a stress fracture is. So you could say you got what appears to be a stress fracture that is extending across the majority of the bone. So that tells you that this person may end up getting a bigger fracture later. But if you say it's only maybe 10% of the bone, then it may tell someone, okay, maybe just stay off using your leg, then maybe go non-weight bearing for a while. Hopefully that gets better. So again, let's look at this. And for those that may need to, so what I really like about Collective Minds is that like everything that you would need in an online darken view, you've got here. So look, we're going to kind of do this. You can really kind of shift around the image to be able to really look at what's going on and rotate and all the rest of it. But I think in this particular situation, I don't think we really need to rotate all that much, right? So again, let's use the pencil and try and draw things around. And we can see that, first of all, this is not a young patient. We can see that this person's got fused bones. And we can see that their humerus is sitting here, so it's not dislocated. And we can see there's this abnormal looking lesion over here. Can you see that? It looks like a big cauliflower, doesn't it? Sitting that way and that way. And this, what they would call is that stipple kind of calcifications, and you got a few radiolucencies in there. When you get these kind of radiolucencies within a lesion, then you're probably looking at some sort of chondroid matrix within that lesion. And because of where it is kind of in that shaft of the bone, you have to kind of go with an exostosis, right? That's what this is. And the only unusual thing I would say about this particular exostosis, generally speaking, it should point away from the growth plate. So the growth plate would have been around here and it should be pointing away, but it doesn't feel like that. And maybe at some point it did, but it's become very, very thick in that medial aspect. So it could have been like this at some point, pointing that way. But over time, it started to become a little bit more like a pyramid, doesn't it? With a big kind of cloud sitting on there as well. The thing to worry about is if someone's come in with pain. So these can be points of weakness in some way, some situations where if they get large enough, they can result in abnormal translation of forces as someone is using their arm. And you can end up getting fractures. But actually, the more scary thing is that if it starts to cause pain or get big over a short period of time, it can actually have something called, it can become, can transform into a sarcoma, essentially become an aggressive tumor. And so in that situation, you may need to do an MRI scan to have a closer look, see how big this chondral cap would be around this area, and also see whether there's any soft tissue reaction. Now, interestingly, because these things have been around for so long, they often have their own little bursa. The body kind of produces this kind of fluid area around it to try and reduce the amount of inflammation that can happen. So you can get like very kind of a bursa sitting around the exostosis as well. But it's really that chondral cap and the general inflammation of the bone that will start to get worried. And obviously clinically, if it's got bigger and the person's got pain, then you really got to think about, whether this is something more serious. Now, this one I thought was quite interesting. I hope people don't go to the CT straight away. Let's go straight for the X-ray. So again, what we may need to do is just window a bit. And again, you can see this platform very good. You can do this here, and you can window, and start to take a look. Now, you can go down the idea of, okay, let's use the check areas that I had. But I think in this situation, I think we can all see that there's something not quite right in this particular area, this middle area over here. So I'm going to just point it out for those that can't see it. That does not look right, does it? So if you look at the lung over there and look at the lung over there, there's clearly some sort of increased density within that area. Now, the thing is, what can cause increased density within the lung in general? So if you imagine the lungs to be like a big net kind of situation, it could be lots of gunk stuck in the net. So that would be like a consolidation with air bronchograms, or it could be like a fish stuck in the net. That'd be like a tumor or something like that. But this one doesn't, it looks like there's no air bronchograms within there. But interestingly, it's also got this sort of linear horizontal line that's going across like that. And that's kind of as if someone's literally got a cup. There's, look, Collective Minds cup. You pour some water and you've got a water sort of level sitting there. And that's what's happening inside the chest. So when you've got something like that, you've got to start worrying about there being an empyema, like a cavitating lesion that's causing destruction of the lung parenchyma and resulting in a fluid level sitting within there. And in the absence of trauma, if there was trauma, it could be blood. In the absence of trauma, yeah, you're looking about an empyema or something like that. And thankfully, we do actually have a CT scan here. And again, you can download the images and you can see quite quickly. The images have come across literally no downtime. And there's quite a lot of you online, right? Let's have a look. How many people have got online right now? 91 people. And so hopefully you're not feeling any slowing down of the service that we have here. As you kind of scroll through, can you see that over in this region over here? Let's just draw that out. Can you see that? And there's that fluid level right there, yeah? And exactly right. So someone has said that, could it be a bullae that's become infected? Let's go to the lungs and see what the lungs look like in general. And the lungs don't look great, do they? You can see that there are multiple sort of subpleural emphysema areas, apical emphysema areas as well. And you've got this area over here, exactly right, that you are worried that there could be an infected bullae. It may very well be. And also you've got this sort, can you see around there? If we go to the bone windows, if we go bone windows, so pressing the numbers here, you see there's hyperdensity over here. So you only really get hyperdensity within the pleural space if there's been repeated injury over time or inflammation, or someone's had they've had exposure to asbestos, because that in itself is causing irritation over a long period of time. So this looks like it's been there for a while. I mean, there's some extensive calcification located in the area. So the body's been trying to deal with this for quite a long time. And interestingly, if we were to get the layout here, go here, and say, look, I'm getting two images up at the same time, you can see the fluid level being like this, but the fluid level being like this. And it's all to do with gravity. When we had the patient on the X-ray, they were standing up, so all the fluid is going that way. Now the patient is lying down on the bed looking upwards. Now the fluid is all in that posterior aspect over there. So that's why sometimes, you see something on the X-ray and it doesn't quite look the same as the way you'd expect on a CT scan. I'm just going to show you one more thing, which is really great about this platform, is that you can actually do a coronal images as well. So unfortunately, I think the images are slightly off and you're not getting the full image here when I scroll through, but you can see that you can do the coronal images to try and see what it looks like, and then maybe even compare it to the X-ray and say, okay, well, it looks like that there, it looks like that there, and then start comparing the difference as well. So someone's asking, is the fluid pus? Exactly, that's a very, very good question. Now, it's difficult to know on CT scan, very, very difficult, because fluid is fluid. It could be blood, it could be pus, it could be pleural fluid. The only way to know is to obviously correlate it with the clinical history. Does a patient have an infection? Have they had history of infection? Are they coughing up any sputum? Have they had recent trauma? Because that could be a contusion that's resulted. So when you have a lung injury, you can get bleeding within the lung, and you can start to have breaking down of some of the lung parenchyma, and then you can end up having these sort of fluid collections. And then if all that fails, you just may need to do a CT guided or even ultrasound guided aspiration of that fluid, send it off to the labs and find out exactly what's going on. Now, one of the things that you would be worried about in a patient like this, by the way, is looking at those lungs. It looks like they may have been a smoker, because when you smoke a lot, you end up having apical sort of emphysema. This person's got bilateral apical emphysema and multiple areas of lung damage. So then you do also have to worry that, what if this is a malignancy, right? Because the problem will be, so the problem will be when you've got someone who is a smoker, you can actually get carcinomas, like squamous carcinomas, that result in cavitation and therefore may look kind of a similarish thing. So you've got to be very, very careful and basically take this to respiratory MDT, maybe take a sample and send it off to the labs. Okay, so let's have a look at this case. So what we're going to do is just click on download again. So download, and once that red mark goes all the way across, then we're pretty much good to go fully. But even before that, you can actually start scrolling through and seeing what's going on. So for those of you that are with me doing this at the same time, please feel free to scroll all the way from the top to the bottom. Tell me what you think, and we'll go through it as well. So looking at this, we go from the very, very top. We know this is a contrast enhanced image. You can see that there is some contrast sitting within there. And then coming further down, you can see that the portal vein is sitting over here. Now you come down, having a look. I'm going to do one scroll for those of you that haven't been able to access the case bank just yet. All the way down. Okay, so at the moment, we haven't seen anything grossly abnormal within the abdomen. We may feel like that anyway, but we'll go through it in a systematic way, the way that I would teach my registrars how to look at things. So first off, this is the liver sitting at the top over here, and that looks relatively okay. This is a portovenous image, because we can see that the portal vein is brighter than the aorta. And we look at these kidneys actually, and looking at those kidneys, they look like they're a bit expanded. They look like kind of Mickey Mouse hands. For those that don't believe, let's go and have a look at the coronal images and have a look at what they look like. And yeah, can you see how sort of dilated they are? Because they should be very, very sharp, and instead they look very, very globular, like a cauliflower thing going on there again. And so there's clearly something not quite right about those kidneys, and it's bilateral as well. So you think to yourself, okay, what could be causing that kind of problem, right? Spleen, you're right. Yeah, there's not much of a spleen there. I mean, there's that little circle there, so like a little splenunculus, but the spleen is not really there anymore. And then as you come down, you've got to follow these ureters. Now, interestingly, what I would advise everyone to do is not just stop looking for where there's an obstruction. Have a look at the ureter wall. And if we do the magnifying glass thing again and have a look, can you see that the ureter wall looks a bit sort of thickened, right? It looks a bit slightly hyper enhancing. And you come down, you can't see any calculus there. There's nothing obstructing there at all. And then someone has pointed out that they felt as though this lymph node does look big. It's true. And there's some hypodensity within there as well. So that's also true. So there could be some necrosis of that lymph node. So now you think, okay, so I've got a necrotic looking lymph node, bilateral hydronephrosis and hydrouretes, but I haven't seen a mass that's causing the problem. There's no calculus and there's no urinary bladder lesions from what I can see. So you've got to think to yourself, like, okay, what else could be causing this, right? Now, interestingly, when you come down to the aorta level here, you can see that there's a soft tissue density sitting around the aorta. So look, there's the aorta there. Let's draw that. So let's draw that. There's an aorta, and there's soft tissue density sitting all the way around there, right? And so when you've got soft tissue density sitting all the way around there, that must mean that there is some abnormal enhancement. There's some sort of density there. And in fact, it's kind of pulling the ureters towards it. So if we go from the top and work our way down, you can see that ureter there is going towards it, and then it's very difficult to follow. It's exactly right. A few people have thrown it out. You're completely right. So this is called retroperitoneal fibrosis, and there are a number of causes that can happen. A number of causes that can result in this, right? In this sort of situation, it can be radiation. You can get some medications can actually cause it, like beta blockers, hydroxyzalazine, and lymphoma can also be a cause for this. So what do we do? Where do we go? I mean, yeah, someone's throwing out a few more. Yeah, exactly. Basically, all of those. What do we do next, right? Because on imaging, there's only so far you can go. You can say, look, bilateral hydronephrosis, we've got bilateral hydrouretes, soft tissue enhancing lesion around the aorta, fat stranding around the aorta. What's the cause? It could be any of those things, but someone's done the right thing here. We've seen that there is an abnormal looking lymph node. So the next thing to do is to suggest that under ultrasound guidance, we take a sample of that, send it off, and see what on earth is causing this particular problem in the first place. But anyway, I thought it's a very good case of thinking about what are the possible causes of hydrouretes and hydronephrosis. And so far, I've shown a few stones as we've done things, big hematomas and that kind of thing, but I've never shown you guys retroperitoneal fibrosis before. So hopefully that's a good case. So let's go to the next case. No questions yet. We've answered that. Yeah, good, excellent. Again, let's download this. Been rapid today, so we've got the cases coming through, and so this person is let's have a look. So let's go from the top. Okay, first off, let's go from the top, coming down all the way down. Yeah, good. Someone's come out with some of it. Come down, come down. So just waiting for those last bits. So when we go from the top, first off, what is it? Okay, we have got what looks like a portovenous image. That looks slightly brighter than the aorta. That's fine. So we've got contrast. Going from the top here, we can see, yeah, exactly right. There is multiple areas of hypodensity sitting throughout the liver. The liver itself also looks very, very irregular, right? The liver should be very, very sharp, but it's not. It looks very, very kind of lobulated, right? So that's another thing, yeah. So very, very lobulated. Multiple lesions in the aorta, in the liver. We've got a gallstone here, but actually that doesn't look like it's causing very much issues, and it wouldn't be causing that sort of abnormal appearance to the liver. So there's a malignancy which is non-related to the gallbladder at all. Now coming here, you can see the IVC, and can you see that how that kind of comes in and disappears? That little kind of nodule there, that lesion. So let's do that again. Can you see that? If you keep your eyes on that area there, it comes in and disappears. So clearly there's a lymph node there. That's what lymph nodes look like. A few more lymph nodes are here and here, and this is called the aortocaval area. And coming further down, you can see there's this sort of linear areas over here, which is going to be fluid. And someone's come out with a very good answer there. But when you come further down here, you'd start to notice that there's these two abnormal looking lesions over here. Can you see those over here, right? So you think, okay, maybe those are bowel. Maybe that's what's going on. So you start following it right from the bottom all the way up, and just keep following, keep following, keep following, keep following. Try and follow that bowel. And you can see that bowel never goes anywhere near that lesion down there at all. So the bowel is separate, coming up to here and going right across the top. That bowel doesn't go anywhere near this very, very abnormal area over in this region here. So let's get that pen just so everyone knows. There and there, two lesions over here. So what are they? They could be lymph nodes, I guess. Yeah, I mean, they could be lymph nodes, but actually they don't behave like lymph nodes because they're on that side, but they've kind of got this lower density located with the central aspect. They're very, very lobulated and sitting in both areas of the adnexa. So adnexa is a clue. These are essentially ovaries. And what you have are these big lesions. So someone is saying, is it ovarian cancer with liver metastases? But actually, it's not that, because it's quite, I mean, yeah, it could be, but when we're talking about probabilities and possibilities, it's less likely you're going to end up having a bilateral ovarian malignancy. More likely something's affecting both ovaries and something's also affecting the liver. So therefore, this would mean that these are actually part of the metastases as well. So you've got disease spread into the liver and you've got disease spread into the ovaries. And therefore, this is known as a Krukenberg's malignancy. So then, yeah, someone said, look, let's have a look at the adrenal glands. So adrenal glands are here, and the other adrenal gland does look a little bit large. Again, that's not going to be the cause. Actually, most of the time, Krukenberg lesions, Krukenberg malignancies exactly happen because of a GI malignancy. And when you come up to this area here, right there, can you see that esophagus doesn't look quite right? It looks very, very thickened, circumferentially thickened. There's a lymph node there as well. Coming further down, looks a bit thickened. And then you get into the stomach. So actually what we have on this one image or one scan is the primary, which is the esophageal malignancy. You've got multiple liver metastases, and you've got malignancy which is spread to the ovaries. And that malignancy spread to the ovaries is given its own name, known as a Krukenberg lesions as well. So quite a nice case, well, not a nice case, but an interesting case to learn from here. Okay, so we have got, oh yeah, through in a trauma for you guys. So again, let's download this one. So trauma, motorcycle accident, right? And so obviously you're going to do all the really important things. So when it's a trauma motorcycle accident, I'm always really worried about these sort of, you can get these pelvic book fractures where the pelvis opens up and they're bleeding. So first off, I would always do is make sure there's no intra-abdominal or pelvic hematoma. Then I'll go across to the bone windows, which is number 4 on the keypad, and just have a look and see whether you can see any fractures anywhere. And actually, you can't really 100% say there are any fractures anywhere at all. Now, with pelvic injuries, sometimes you get bladder injuries as well. Difficult to see or say that there's a bladder injury at all because first off, we've got no fractures anywhere, and that urinary bladder looks pretty uniform and there's no fluid around that area as well. So I can't say that there is a bladder injury, but there is what looks like a hyperdensity area over here. Can you see that? And so, yeah, there is a big hematoma sitting over there. And so that's what's essentially happened is that you've got your fascial plane between your subcutaneous tissues and the fascial plane between the muscles. And when you've got this sort of traumatic injury, they can actually shear off from one another and you end up getting this extension of bleed. And exactly right, someone said it, a Morel-Lavelle lesion. Now, generally speaking, that should just get better by itself. It will kind of harden up. It may get reabsorbed in the body. There's not really much more to do. I have had situations where it's got so big and so painful, we've ended up having to actually aspirate it. But then the other thing of concern is sometimes, even on the scanner, the person is still bleeding. Now, with this one, you can't be 100% whether they're bleeding or not because we haven't given any contrast to this patient at all. See, look at the IVC, look at the aorta. There's no contrast in the scan. All we have is this hyperdensity here, so we don't know if they continue to bleed at the time of the study. Now, one of the things is that sometimes on the non-contrast study, you could tell whether they're actively bleeding if you've got a small area of hypodensity because the blood hasn't had the time to clot up. So this is kind of semi-congealed blood. But if it's still actively bleeding, if it hasn't had the time to clot up, you may notice that there's kind of a little hypodensity somewhere. Very, very difficult. In theory, it could be possible, but I wouldn't really, I've never really seen it apart from in the brain. When you get subdural hematomas, you may see a hypodensity somewhere there showing you that there's active bleeding. But in these situations, you may end up having to bring them back for a contrast study to see if they continue to bleed, because if they continue to bleed, you may need to send them to the interventional radiologist who will therefore then go and stop the bleeding from happening any further. Right, so now we are going to this one, and I have got a poll ready for you guys. So this is the next poll. I'm going to download the images. What I'd like you to do, hopefully, is to answer the question once you've had a... Oh, did I skip one? So let me go back one. Case 11. Let's go to case 11. So apparently I've skipped one. Okay, so let's download this one. Okay, let's have a look. Right, so this is a contrast enhanced study. Scrolling down, scrolling down, scrolling down, scrolling down. What do we think is going on here? Okay, so let's go from the very, very top. So I feel like they're an older person. You can see from the way the bones look, you know, after a while you get used to that kind of thing, being able to tell, going all the way down, going all the way down, going all the way down. And actually, can everyone see that? Yeah, so, oh, yeah, you got it straight away. Well done. So what we can see here is that there are multiple loops of dilated small bowel, and the dilated small bowel is here. Look, this is bowel, and you can see valvular convergence going all the way across. So this person has got multiple loops of dilated bowel. So the things that I would do, so there's another case that will come in useful now, but this is one of the things that is genuinely, when when I'm on call and I see multiple loops of dilated bowel, the first thing I do is look for a hernia. I look for a hernia straight away. You go all the way down and look for a hernia. Inguinal hernia, no, there's no inguinal hernia there. And then you look on the other side, no inguinal hernia there, no femoral hernia there either. But actually you may have spotted that there is this lesion over here. That lesion, look at that, where does it go? Coming out, it actually continues into this bowel. Can you see that? It goes into there, goes into there, and goes into there. And it seems to be between the adductor muscles. And so therefore this is an obturator hernia. They call it an obturator hernia. And so a little bit of bowel has kind of poked through there, got stuck, and then resulted in a small bowel obstruction. And generally speaking, this happens to the very, very elderly patients as well. So that's one of the things to consider when you're looking for it. But genuinely, when I do these on-call scans, I see dilated small bowel, I go straight to the groin. Have a look, just in case. That could be easy win, easy pickup. If there's no groin hernia, then I start looking for any anterior abdominal wall hernias. No abdominal wall hernias, then I've got to start following the bowel and trying to figure out where on earth I am. Okay, so we are, so I missed number 11, I went to 12, and now let's go to the poll. Let's go to the poll. Yeah, someone said the coronals and sagittal NPRs are very nice for bowel evaluation. That is true. These slices are a bit thick just for, fluidity purposes. But the thing is, like, I'd only do that if my first two go-tos have not worked. So if there's no hernia, if there's no hernia, then I'd be like, okay, you know what? I'm going to have to start doing the long graph. So first off, after not finding the hernia, I would start following the bowel. And the next thing, which is actually quite good, we've gone from one small bowel obstruction to this case. And this is another little trick that I think is very, very useful and something that's helped me enormously when I'm doing these on-call scans. So let's go through. Again, this is a contrast enhanced study. We can see there's some contrast in there. That looks slightly brighter than the aorta. So this is a portovenous phase. And again, as we scroll through, you can see that there are multiple loops of dilated small bowel. Can you see that? And there's valvular convergence going across. So then what I would genuinely do is go to the groin and see whether there's any herniation. So they do have bilateral inguinal hernias, but they don't seem to have any bowel there. Let's look for any obturator hernia there and there. No, nothing there either. Okay, so we're going to have to do the long haul. We may have to figure out where on earth this obstruction's come from. So the next thing, you may want to just start going for the bowel. So go from the stomach, go all the way across. You can see it goes this way, go this way, go this way, and just keep following and following. But the next trick is something that has helped me through a few sticky situations. So first off, I put a poll out here. What do people think? Go put out your answers, and I'm going to start trying to work our way through and figure out, we're going to try and figure out together what's going on. So first, let's go through here. So following the bowel, it gets very, very difficult to follow here. Feel like we can just maybe jump across to this area. We're going to go across this way. Okay, it's kind of collapsed a bit, but again, dilated again, collapsed a bit, dilated again. Oh, and it gets difficult, doesn't it? You think, oh, what am I going to do? So then one of the other things to do is look for something called fecalization, right? Now, what ends up happening is that the small bowel should never have feces really inside it. And feces is what you get in the large bowel over here. Can you see that? That kind of material where it's kind of very it's got lots of air within it. You should really only have fluid. So you only have like feces within the small bowel if there's obstruction, there's lack of flow of fecal material through. It gets sitting in that small bowel, and the small bowel does what it's meant to do, take fluid away from it, and eventually becomes like feces within the bowel. And then you've got to look for whether there's any feces sitting within the small bowel. So let's go through, and look, can you see that there? That looks like feces, but it's within the small bowel. So feces should only really be here in the large bowel, not small bowel. So if that's the case, there must be some sort of obstruction somewhere in close proximity to this area. And you go through and you start to notice, actually, yeah, look, it narrows around this area here and then becomes thin there. And it's around there that it starts to become dilated. And you work your way away from there, and yeah, it's dilated and continues to be dilated. So exactly, a feces sign is really, really, really important to help me out through so many occasions where you know, like you want to help the person, you want to get to the answer as quickly as possible. Now, in this situation, we can't see a lesion really going on there. We can't see any big masses or anything like that. What we can do is say to the person, yeah, it could be an adhesion, but obviously we need to look at the clinical history. In this particular situation, I think this person ended up having an underlying inflammatory bowel disease, which is resulting in this particular situation. But at the very least, you've got bowel obstruction, which needs surgery, and you've told the surgeons where to look. Like you've said, look, in the mid to lower abdomen, this particular slice is where I think the obstruction is occurring, and this is the problem. And no, we can see from a few people have said it's large bowel, a few people have said it's perforation, some people have said ischemia and volvulus. So it's not ischemia because you can see the bowel enhancing nicely. There's no air around the abdomen in general. And I'm going to show you a case of what perforation looks like in general in a bit. So don't worry, I'm going to be able to show you guys the difference in just a minute. But anyway, the main thing here, what I wanted to show you guys is feces sign. If you're ever worried, if you can't find the hernia, you can't find the cause, look for feces sign, and that may actually end up helping you figure out what the underlying problem is. Right, so let's go to this case here. And so it looks like we have a few things going on. So let's go to so what's really good about this, depending on the size of your screen, so thankfully I've got quite a big screen here, but you can actually have multiple images on the same screen and then go through it. So let's download the images before we do anything else. So what do we have here? So on the left here, it looks like we've got no contrast within that study. And on here, looks like we've got contrast. So let's have a look. What could be, so when you've got a non-contrast and a contrast, you immediately start to think to yourself, okay, there's a reason why we've taken an image of someone without contrast and then taken an image of them with contrast later. There must be something up. We're looking for where contrast has gone. So either we've seen a malignancy, which is now enhancing, or we're looking for contrast where it shouldn't be at all. Right? That's going to be one of the things that we're looking for. And in reality, what you really need to do is sort of take it sounds weird to take a mental image of images, but you've got to take mental images of one and then look at the other. And then if you see something that's slightly off, then you've got to start looking for where that slight offness has come from. Now, the clinical history behind this particular person, and it may give you a clue, and someone's come out with something which is actually related to the underlying problem that's gone on here. So first off, yeah, when you look at this non-contrast image, you can see that there is this there is fluid just sitting around the liver. So this is ascites, and you may be worried, okay, how do I know whether this is blood or not? And in real life, what you need to do is get your Hounsfield unit, measure it, and see whether it's high. And if you're not sure whether it's high or not still, then go to something that you know to be true. So you know the gallbladder is going to have normal fluid. So if you measure the density of the fluid within the gallbladder and then go to the density within the fluid within the abdomen, and they're about the same, you know it's fluid but not blood. But if they're about the same density, you know, if the fluid is higher density than the gallbladder fluid, the fluid within the stomach, then you're probably looking at blood, right? So when you're looking at the liver, you can see this particular liver looks very, very irregular. So yes, someone has said it, they're looking at cirrhosis, right? And there does feel like there's a lot of fluid and there is a gallstone within that region, but that fluid around there is probably more likely to be related to the ascites rather than inflammation in itself. And remember, there must be a reason why we've gone from we've done a non-contrast and contrast study. There must be something happening. So now what we do is come to this area over here and we can see, yeah, look, that liver is very, very irregular. That fluid doesn't look like it's particularly dense and there's no contrast sitting within that fluid area to suggest there's any bleeding. Yeah, I guess you could say that the gallbladder is slightly hyper-enhancing, but what ended up happening was this patient came in because they had hematemesis. They were vomiting up blood, right? So now you've got to look at so come back to the non-contrast image and have a look at the esophagus, which is over here. Follow it down and you can see the stomach, you can see the stomach over here and kind of take a mental image of what that stomach looks like, right? And there doesn't look like there's any hyperdense material in there. If you've got hyperdense material located within the stomach on the non-contrast study, it's more likely they've eaten something like a tablet, I don't know, maybe swallowed a bone or something like that. But it's not going to be blood because there's no contrast there. But now when you look at this image and go for the similar area, you can start to see that actually there is this hyperdensity there. And compare the two. Look, let's go back to the stomach. That area there, nothing. That area there, there's some density. Coming further down, some more density there. Further down, no density this way. And then you kind of have this area. You can see that there. where it's very, very dense. Let's get the magnifying glass here and just show you. Can you see that there? Zooming in, very, very hyperdense in that area, very linear. Come to that same region on the non-contrast study, and that area doesn't look like it's so hyperdense as well. So then now you can see that there what looks like there's varices. You've got an irregular contour to the liver, and you've got multiple varices, and this one seems to extend into here. There's some hyperdense fluid around that area and extends superiorly towards the lower esophagus as well. So that's going to be the bleeding point. Exactly right. Someone said variceal bleed. Yeah, that's a variceal bleed. So this is a variceal bleed. And that's why you've got this situation. They end up needing to go and get this. You need to go with an endoscopy and go and stop this bleeding from carrying on. But this is why it's really good to find contrast. In these situations, we're looking for bleeds. Sometimes it's not so good just having this on its own, because then you have nothing to compare it to. And then there's no point in having this non-contrast image alone, because then you don't know what's going on. And that's why you have both, and you look between the two, looking for where there's contrast where it wasn't there before. And in fact, this is the portovenous image. And now can you see this is the arterial image? How to notice the arterial image? Look at the aorta and how bright it is compared to the portal vein, which is not that bright. And on the arterial images, let's have a look. You can see just around there, there's that wispiness going on this way, this way, this way. So they're bleeding in the arterial phase. And as we've waited, take the next CT scan, that blood is pooled in that upper stomach area as well. So yeah, quite interesting case there, and a good way to show why contrast is useful. So we've been very, very lucky today. We have had someone actually give us a few cases. Now, I'm not going to promise I know the answers to some of them. I'm going to try my best. And if you do know the answer, then please do let me know what you think is going on. But this person has given us a case. We've got a 35-year-old female with abdominal pain. They've had no trauma, no surgery, no trauma. And so now what we can see here is that they have had oral contrast. So you'd see all this stuff over here, this bright stuff, that's contrast, but they've also got IV contrast as well. And we can see that the portal vein is brighter than the aorta. So that's, so we know it's a portovenous image. Now scrolling through, at first glance, you don't feel like there's very much going on. There doesn't seem to be much really happening. So you think, okay, well, it's fine, isn't it? What's the big issue? And we don't see any bowel obstruction because the small bowel looks okay as well. That's a small bowel there. Large bowel doesn't look like it's obstructed as well. And we've given oral contrast. So one thing to do is to make sure that the oral contrast has gone through all the way through to the rectum as well. And you can see, yeah, there is some contrast located within the stomach. So we're not dealing with obstruction. They've drunk something and it's gone all the way through. So then what do? We need to figure out why this person's in pain. And we go all the way to the air windows, the lung windows, and you're scrolling through. And, after a while, your eyes get used to where the air should be. So I see air there. That's fine. Air's located within those areas. But as you come up to the top, you start to feel as though, hang on, there's a lot of air, like dots of air within that area. What on earth is going on there? That doesn't seem right. And coming further up, you think, okay, some air, that looks like the bowel wall there. That looks like bowel wall there, but these dots here looks like air outside of the bowel. So therefore, we're dealing with a perforation of some sort. Now you've got to start thinking to yourself, okay, why has this person got perforation? They're fairly young. Generally speaking, it's going to be, usually go for the common things, right? Common things are going to be a perforated duodenal ulcer, but actually the duodenum looks completely fine. And this is when it may be useful to go for the coronal images and have a look and see what's going on. So look, that's the stomach, that's the duodenum. We're going across like so. And again, it looks completely fine, doesn't it? It doesn't look like there's much going on there. And then when you come up to here, go up to the lung windows, can you see all that air is there? It feels like you can see a bit of feces like we saw earlier, but some feces that's slightly outside of the bowel there, you see? So although we are not, we can't see exactly what's causing the problem, it feels like a lot of air is located in what is the splenic flexure and the possibility of some fecal material located within the area over there. So even though I haven't been 100% about it, you'd say to the surgeons, clearly perforation, multiple locules of air located within the region of the splenic flexure. I'm concerned there could be some fecal material located within this area as well. And therefore I'd be concerned that you may need to go in and have a look. So they apparently, thank you so much for giving us a bit of follow-up. So someone has given us a bit of follow-up. They did a CT scan 4 days later, and there's the same quantity. same quantity of air there. So very interesting. At the end of the day, you've got someone who's got pain. You've got multiple locules there in there. I would have thought that it would be a good idea to actually do some explorative surgery and see what on earth is going on with that particular patient. So what we'll do, we're going slightly over time. You know what? Today's special. I'm in the headquarters of Collective Minds, so I hope you don't mind. We'll in 10 minutes more. We'll go through these last two cases that someone's kindly donated. Now, this is where I'm going to have to admit that I am not an expert in urogenital imaging at all. But what we can see is that we've got an oblique view, and we can see that there is some contrast going in this way, and this looks like it's the urethra. And this, what have we got here history-wise? Male 46. So we've got the penile urethra, and around here you'd have the prostatic urethra, and around here you'd have the urinary bladder. We've got, I think, 2 phases from what I can see there. So contrast is sitting over here on this one, and you look here, not much in the way of contrast. So what I think is happening, and you may be able to correct me if I'm wrong, is that we have put some contrast in this way, right? And so we've got contrast going all that way, and then it starts to peter out, and then it feels like there is some contrast getting into the urinary bladder, but there could be something sitting within there. So no trauma. It could be a multitude of problems, right? So either you've got like a stricture, where you've got stricturing of the prostatic urethra. You could have a big prostate there. You know, it could be a big prostate that's causing that kind of problem as well. And the other thing, I mean, look, I suspect that filling defect is probably going to be the balloon of the catheter rather than being absolutely like an actual pathology. But you'd ideally want to have more phases, because you've only got this one, and when you're live, you can kind of rotate the person around. But this looks very, very thin around here, and this is where the prostatic urethra would be, and therefore I would have thought that in a male patient with that kind of picture, I would have gone for something like a enlarged prostate. But then if it's like, so you can see how this tapers and then becomes wider. If it suddenly kind of becomes small like this suddenly, then you may be looking at stricture. That's when it's like very, very small in one area. But if it's kind of tapered like that, then you'd be more towards the idea of this being a prostatic urethra. What are those with thin filaments images? So so around here, so thin, not sure. So these kind of areas here where it's kind of linear like this, that's going to be the urinary bladder pretty much collapsed around the balloon, I suspect. I think that's probably what it is. But yeah, I think this is an interesting case, but I'm gonna have to admit, I haven't done one of these in absolutely years, like absolutely years. Right, and so this one I thought was really interesting, again, because it said here, 17-year-old male who fell down. So generally speaking, when you're looking at these, you've got to go for the high yield areas. Go and have a look at that lateral malleolus, have a look at that tibia, make sure that everything looks okay. And you've got to zoom in a bit and just have a look. And I haven't seen any fractures anywhere, right? And there is something that I thought was interesting, which I will come to, and hopefully I'm correct about it. So look, there's no fractures here. Look, there's no osteochondral defect. That all looks very, very solid. And come across like this all looks okay. This looks okay. So then the thing that kind of struck me as we kind of go through the images is that navicular. Can you see that navicular looks like this, and that's an enormous gap. And I don't know whether that is because of the angle that we've taken it, but in truth, even whatever angle that you've taken an image, I've never really seen a gap like that so big. But at the same time, yeah, there does look like there's a bit of fluid in there, but this looks like it's been there for a while. And I'm, after looking at this image, I was looking around, and there's actually something called Muller-Weiss syndrome, where it's something like Kohler's disease, where you get avascular necrosis of the navicular, but it happens in adults. And even after avascular necrosis of the navicular, once it heals, you can get sort of very, very comma-shaped navicular like this. So this may be that situation where you've had a chronic situation of previous avascular necrosis, which has subsequently healed, and you've ended up having this sort of very, very comma-shaped navicular. But I haven't seen anything acute. Someone said this person had trauma, but I can't see any obvious fractures or anything like that. But I thought it was quite interesting, just because I've never seen, not never, I have seen comma-shaped navicular, but not quite like that. And I suspect that's probably what's going on here. But yeah, you could let me know at some point in life what the outcome is. But a very interesting case, and honestly, I really, really do appreciate it. I'm not saying I'm always right. I think we do these things to learn from each other. And what I would like for you guys to do, I mean, we've had so many people turn up today, so it's a real honor to obviously be the Collective Minds headquarters who allow this to happen, who give us a platform to be able to teach one another, give us a community to be able to work from. Would I order a CT on this patient? Probably not, unless you're thinking that there's pain on this patient. I'll probably do an MRI scan just to make sure there's no inflammatory changes or anything like that. So anyway, I hope that's really useful. Genuinely keep atting me, find me on social media, feel free to message me. Do get involved with Collective Minds as a platform. They are the ones who's making all of this possible, monthly teaching possible. They've really given me a real great platform to be able to share my passion of teaching and learning to everyone. So as always, we've gone slightly over time, 8:06. I hope you guys, I haven't ruined everyone's evening. From me, goodbye. And as always, thank you to Collective Minds and everyone there. And I'm going to give it to Seidel to just see us out. Thank you, everyone. Bye.
Yeah, Imran, well, thank you so much. I mean, a wonderful webinar as always. And the reason why we do these webinars and the reason why it's so good is because we get the feedback from you. So after each webinar, we send out a link. So I just sent it in the chat where you can see it's everyone. So do take some time and fill that in. So if you want to see some more plain field webinars, if you want to see some more cases in, prostate or, pediatrics, let us know. And I would like to say a big thank you to all nice comments for previous, feedback survey. It's been great. And I think we have a lot of thank yous and a lot of nice comments in the chat, Imran. So you should be very proud. It's a really good webinar. And I think most of everyone who came tonight really enjoyed it. But as always, take some time, fill out the feedback evaluation form so you can get the CPD certificates. And we will see you on the next webinar, and we will send it out as usual. So just remember to register and turn up. And thank you so much for being so interactive, everyone. It's truly a blessing. So all right, goodbye from the Swedish headquarters in Collective Minds. All right, bye-bye.